Welcome to Hand Surgery Resources YouTube video on glomus tumors of the hand and finger. Glomus tumors are benign papular nodular lesions that predominantly appear in the subungual region of the finger. These benign hamartomatous vascular lesions were first reported by Wood in 1812, but it was the pathologist Pierre Masson who in 1924 first made the connection between the glomus temperature regulating structures and the glomus tumor. The pathological evaluation of glomus tumors shows a proliferation of homogeneous regular glomus cells with round to ovoid nuclei in a myxoid matrix with thin-walled vessels. Next, let us consider the incidence and location of these lesions. Glomus tumors are rare and account for less than 5% of the soft tissue tumors of the upper extremity, with 75% subungual location. These lesions commonly occur in middle-aged women. The symptoms of glomus tumor include paroxysmal pain, cold intolerance or cold sensitivity, point tenderness, ridging of the fingernail, and blue to purplish nail bed color changes in some cases. Physical examination signs of glomus tumor include cold hypersensitivity, which can be elicited by application of a cold pack, ice cube, or cold spray, pinpoint tenderness at the lesion as seen in the clinical triad, occasional ridging of the nail secondary to tumor pressure on the germinal matrix, and finally localized visible blue to purplish discoloration at the site of the lesion. After reviewing the signs and symptoms, the basis of the glomus tumor clinical triad should be easy to understand. Before modern ultrasound and MRI imaging were available, the clinical triad of pain, cold sensitivity, and point tenderness that Carroll emphasized in his 1972 paper were key to making the diagnosis of the glomus tumor. At that time, only pathological evaluation of excised tissue could confirm the diagnosis. Next, let's review the following patient examination, which emphasizes these clinical points. The clinical triad that is associated with glomus tumors is exquisite pain, point tenderness, and cold intolerance. When examining the patient with a potential glomus tumor, we look for ridging of the nail and purple discoloration underneath the nail caused by the hemangiomatous characteristics of some glomus tumors. When testing for point tenderness, use an object like a pen and specifically push just on the lesion, and this should elicit exquisite discomfort. Specialized exam maneuvers have also been used to diagnose glomus tumors. Some examples include Love's pinpoint test to verify the lesion's point tenderness by using the head of a pin to apply pressure. Another example is Hildreth's test, where the temporary application of a digital tourniquet can eliminate the lesion's point tenderness. Or finally, the cold sensitivity test with ice can also be useful to bring out the discomfort associated with glomus tumor. X-rays of most glomus tumors show normal distal phalanx X-rays as seen here. Occasionally, erosions or a dorsal concavity of the proximal distal phalanx cortex can be seen. Ultrasound is another useful tool for evaluating glomus tumors. Here we see the ultrasound of a normal fingertip showing the nail, the sterile matrix, and the underlying distal phalanx. We're ultrasounding this individual's ring finger nail, sterile matrix, and epinicular fold to see if we can localize a glomus tumor underneath the sterile matrix and germinal matrix. Here we see the ultrasound has successfully localized subungual glomus tumor. MRI can also be used to identify, localize, and define glomus tumors, even as small as 5 millimeters. Here we see an axial view of the MRI, a sagittal view, and a coronal view, all of which clearly delineate the location of the glomus tumor. This can be further helped by using contrast. Next, we will discuss the treatment of glomus tumors. Today we're working on removing a glomus tumor from the subungual location in the right ring finger of this middle-aged female. We're going to make a little epinicular incision here and then remove the hard nail, open the nail bed, and remove the glomus tumor from underneath the nail bed. There's no purple hue here, but this patient has exquisite tenderness right in this location, cold intolerance, and an MRI that showed the lesion underneath the nail bed right at the junction of the sterile and germinal matrix. To begin the dissection for excision of a glomus tumor, we're going to start by removing the hard nail plate. First, you loosen up the epinicular fold from the hard nail plate proximally, and then either with a small elevator like this or with iris scissor, you slide under the nail until you loosen all its attachments to the sterile and germinal matrix. And then usually you can simply pull the nail off. And now we've exposed the germinal matrix and the sterile matrix. You can see a little bulging right here. That's the location of the glomus tumor. So next we're going to make the epinicular incision just to allow the folding back of the epinicular tissue as needed. Now you see that it gives us a much broader exposure to the base of the nail. Again, we've seen the germinal layer. Now we're going to make an incision over the glomus tumor very delicately through the sterile matrix, but not into the lesion. Now we're developing a flap of sterile matrix and germinal matrix off the distal phalanx and the underlying glomus tumor. And there's the lesion. Now we have scraped the glomus tumor out. We see just the remaining bone of the distal phalanx here and the ulnar and radial flaps of the sterile matrix. Next, we're going to put that together, approximating the edges, and we'll suture it with some 6/0 plain catgut. When repairing, it's important to use an absorbable stitch here because we will put the nail plate back on as a temporary splint, and we don't want to have to remove sutures from the sterile matrix. We want them to absorb. You'll see here that it takes only 2 or 3 stitches to approximate these edges and keep them together while the healing takes place. We'll cut these sutures fairly short. Now we have the sterile and germinal matrix repaired over the defect where the glomus tumor has been removed. We'll put a single stitch in the epinicium, but prior to that we will clean up the fingernail. We're going to place the fingernail back in place. Now we're repairing the epinicular fold with a nylon suture. This suture will be easy to remove when the healing is complete. Now we have placed the 5/0 nylon needle through the hard nail and through the skin at the tip of the finger, so-called hyponychial area. So this suture is just in place to help keep the splint of the hard nail located during the healing process. At about a week to 2 weeks, we'll remove the nail and allow a new nail to regenerate from the germinal matrix. We should also consider the potential complications of surgical treatment, such as recurrence of the glomus tumor, infection, persistent pain, or recurrence of the nail bed deformity. Before concluding our YouTube video on glomus tumors, let's review some of the key points. The etiology of glomus tumors remains unknown. Clinical suspicion and an awareness of Carroll's glomus tumor clinical triad is mandatory for successfully identifying these rare tumors. Only about 1/3 of glomus tumors are associated with the blue purplish discoloration of the fingernail. Few have nail deformities, and bone erosion on plain x-rays do occur, but not in many cases. Further key points include special exam maneuvers like Hildreth's tourniquet test that can eliminate point tenderness temporarily in the digit, and Love's pinpoint test, which can localize the tenderness to a very specific spot. Ultrasound is an excellent tool for localizing glomus tumors. MRI can verify the presence of glomus tumors. However, false negatives MRI findings do occur. Thanks for watching the Hand Surgery Resource YouTube video on glomus tumors of the finger. For more information, sign on to our website at www.handsurgeryresource.org or find our Hand Surgery Source app at the Apple Store or at Google Play. Once again, thank you for viewing our YouTube video on glomus tumors.